Okay. Well, I'd like to welcome everybody to this talk on lessons from the pandemic for science and health. This is a part of the East-West Center Research Speaker Series. This series is a recurring program of the East-West Center Research Program to spotlight emerging developments across the region. It explores the health, environmental, demographic, political, and economic processes that are reshaping the Asia-Pacific region today and into the future. It gives me great pleasure to introduce Dr. Soumya Swaminathan. Dr. Swaminathan has a distinguished career with a strong focus on bringing science and evidence to bear on public health policymaking. She is currently the chairperson of the MS Swaminathan Research Foundation in India. Prior to that, she was the World Health Organization's chief scientist through the critical first years of the COVID pandemic. Dr. Swaminathan has over 40 years of experience in clinical care and research in tuberculosis and HIV, with over 480 publications and book chapters. She has served with the government of India, been Director General of ICMR, and led many other national and international efforts to build research capacity and translate data into effective programs. She's a fellow of the Science Academies in India, the US National Academy of Medicine, and the UK Academy of Medical Sciences. As WHO's first chief scientist, she built the science division with a focus on research, quality assurance of norms and standards, and digital health. She played a key role during the pandemic in coordinating scientific efforts at the World Health Organization, as well as in setting up COVAX, which was focused on equitable vaccine distribution to low and middle income countries. And she will be sharing with us today the lessons learned from her experience with the COVID pandemic. Dr. Swaminathan.
Thank you. Thank you so much for that very kind introduction. It's lovely to be here. Good morning and aloha to everyone. And beautiful to be here in person at the East-West Center and be able to hopefully interact with some of you after my talk. So what I'm going to do today, I do have a brief PowerPoint presentation. I debated whether to do one or not, but I make sure that we have enough time for questions and discussion. So if I can bring up my presentation now. So it is a very vast topic to cover, obviously. And so I'm not going to be able to touch on each of the lessons learned. And I'm sure that each one of us here and online we all experienced the pandemic. And so we all have lessons that we've learned and we think, things should be different. But I would like to start a little bit by saying something about the WHO, because not everyone understands how WHO is set up. And we heard so much of discussion then and now as to what WHO should or shouldn't be doing. Now, WHO is basically an association of member states. Of course, it was one of the agencies formed after World War II to bring together the countries, as part of the whole UN system. It's one of the few normative agencies in the UN. So the main function really is to set norms and standards for health and to be custodian of data and to make recommendations based on evidence and data. Now, the Secretariat of the WHO, which is about 8,000 people, 2,500 of them are in Geneva. The rest are spread over the 6 regional offices. The Office of the Americas regional office sits in Washington, D.C., entire North and South America. India comes under the Southeast Asia regional office, for example, with 11 countries. So the member states are the ones who actually control the decision-making, as well as the governance, the funding, the financing mechanisms. They have to agree on international rules. For example, the international health regulations were debated a lot before they were agreed. The tobacco framework, there are very few examples, in fact, of international treaties or frameworks. One is the International Framework for Tobacco Control. I think that took something like 5 or 6 years to negotiate. It's a set of rules and laws that are legally binding on countries that sign up to it. And then we have the international health regulations, last modified 2005, and now in 2024, based on the experience of the pandemic, countries did agree that some things need to be changed in terms of uh, uh, the regulations that govern epidemics and pandemics. And then we have the the pandemic influenza protocol that was also debated for many years. And after the H1N1 experience of 2008 and 9, but that is limited to influenza. It's about sharing of influenza data between countries, because as you know, the vaccine needs to be updated every year. So unless countries share the genomic sequences and the samples of the circulating flu viruses, we can't really have updated vaccines. And it was also agreed that in return for that data, the companies would make a contribution to the pandemic influenza program so that it could help. That money could then be used to help countries build their own capacities wherever there were gaps. Now, unfortunately, this doesn't apply to anything beyond influenza. So when we were struck with COVID in early 2020, we had the international health regulations, which were last updated in 2005 after SARS, but nothing else to guide the world during a pandemic. Now, this year, or the countries that have just met in May of 2024 at the World Health Assembly did discuss something called a pandemic treaty, for short, which was really to address this big gap in global, let's say, rules of the road for when a pandemic, because we all know that the next pandemic is a when, it's not an if. And we also always presumed that a pandemic would be caused by influenza, but we were taken by surprise when it was a coronavirus. And so we now have a list of 25 viral families that either already infect humans or can infect humans. And as you know, emerging infections mostly come from the animal kingdom. So 75% of new or emerging infections in humans are zoonotic, which means they come from an animal source. And with globalization, with so much international travel, but also with the huge urbanization that's happening, we're cutting forests, there's loss of biodiversity, there's more movement of animals, closer connection between humans, animals, wildlife. And of course, there's the big illegal trade in wildlife. All of this contributes really to the mixing of viruses, but also bacteria, fungi between species. We have in the US now going on the H5N1 outbreak among cattle farms. It's quite widespread. And there have been a couple of cases in human beings, but it's a matter of time before viruses adapt themselves to living in one species harmlessly sometimes, like bats carry thousands of coronaviruses, which are not harmful to bats. But the same coronavirus moves species, gets into a mammal or gets into humans, and we saw what can happen. We've had 3 coronaviruses so far, the SARS-1, the MERS, which is a Middle East respiratory syndrome virus that is endemic in dromedary camels. And when it infects humans, it is very serious, causes very high mortality. And then we had the SARS-CoV-2, which caused the coronavirus pandemic. Now, the reason I mentioned the WHO was firstly to point out that it's the countries that make the rules, not WHO staff. There's a lot of misinformation out there that some of you might have seen on social media saying WHO is trying to control the world. They're trying to take over all the countries. We're going to have no autonomy left. That's very far from the truth. And then it's also the regional offices have their own elected regional directors. And so it's a little bit complicated because you have the DG, but you also have 6 fairly independent elected regional directors. Of course, they all work together on the core common strategic goals. Now, in 2019, we went through transformation because there was a new director general who'd taken over in 2017, Dr. Tedros. And as part of that, there was a very big focus brought on science and data. And as I mentioned, WHO was set up with science and data at its core, but it never had a science division or a chief scientist. So it was in 2019 that this post was created, the division was created, and I was there already as Deputy Director General. I was invited to take the position of the first chief scientist. Geopolitics, I think we can talk about that a little bit more, but it's extremely important, as we all know, especially during emergencies, and then international treaties and frameworks I mentioned. Now, the toll of the pandemic has been huge. An estimated 15 to 18 million people had already died as a result of either the infection itself, or in many cases, the pandemic contributed to excess mortality due to a variety of other reasons. For example, during lockdowns, if you had a heart attack, if you had cancer, if you had something else which needed attention, you didn't get it, you ended up passing away, not because you got infected with COVID, but as a result of the impact that COVID had. We also saw that there were wide discrepancies in data. So if you look at some of the world maps that we were putting out in the first months of the pandemic, Africa hardly reported any cases. It's not that Africa didn't suffer from the pandemic or people there didn't get infected. There was no testing. There was no capacity for diagnostics. There was a huge gap in access to some of these things. And so we didn't have death records from many countries. As you know, this is one of the critical ways in which we can find out, if you know what people are dying of, you can know the burden of disease in a particular country, and you can make policies based on that. But if you don't have good cause of death reporting, which many developing countries don't have, then you have to use models, and we all know that models have their own drawbacks because you have to make a lot of assumptions. And so we were faced with this issue of the lack of reliable data. And so decision-making also becomes very complex. We also saw that the pre-pandemic level of preparedness was insufficient in the majority of countries, including in the most developed, so-called developed or high-income countries, where there were plenty of hospitals and intensive care units, but public health had been neglected. So investment in public health had been neglected. And in large countries like the US, like India, where you have a federal structure of government, you need good cooperation and a seamless, collaboration between the central and the state governments. And because, we know that states have a lot of autonomy in decision making, but for certain public health functions, if you don't work in a coordinated way, then this is going to obviously result in discrepancies in what happens to people who live in different parts of the country. And we saw that, right? We saw that happening either because the health system in India, for example, we know that there are some states with very advanced health systems, as good as anywhere in the world, with infant mortality rates, the same as Western Europe, for example, but there are other states where the health system is not so good. And so you have very high infant mortality rates, which is a marker of, how good your health system functions. Similarly, if you have good genomic surveillance in one state, but not in another state, if you don't have data sharing, then I think it's very difficult for public health officials to make the right decision. So the lesson here really is that you have got to invest in public health and in universal health coverage. So maybe we can skip this slide because it's anyway a little bit old, but basically to show even today, we're still having these new variants. We still have the variability. You have a spike and then it goes down and then there's a new variant and so on. One of the things, of course, that we saw was the huge economic impact. And what this slide shows is that the impact of COVID-19 in terms of the percentage of countries experiencing a negative growth in their per capita GDP really has been the highest since 1901, more than the world wars, more than the Great Depression, and more even than the global financial crisis of 2008-9. So a health crisis really brought the world's economy to its knees. But we also saw the very different and unequal impacts that this had. The high-income countries were able to put in a lot of government finances into supporting people, whether it was supporting small businesses, whether it was giving social support to the poor, etc. But the poor countries really didn't have the resources to do that. So the poorest in every country, and of course, the poorest in the poor countries or developing countries suffered the most in terms of having to sell assets, using up emergency savings, and even increasing food insecurity. Now, at the WHO, we were actually surveying countries to see how well their public services or health services were operating. And basically what this showed was, in this slide, you can see that a lot of countries reported disruptions in services. Now, this was at the end of 2021, I think this was the third survey. No, this was already 2022. So even at the end of 2022, we see a large number of countries, a quarter of countries, still reporting disruptions in things like maternal and newborn health or sexual and reproductive health services. Now, obviously in 2020, this figure was like 85% of countries reporting disruptions. That means there was no resilience in the system. There's such a big shock that basically things collapsed. And as we know, many hospitals just turned into COVID hospitals, which meant a pregnant woman, for example, had to go looking for care from hospital to hospital, which often meant that she delivered on the way, or sometimes even died. There were some very tragic things that happened. Okay. So there was, apart from the huge stress on the supplies and equipments, of course, the burden on healthcare workers was huge. And we saw not only a lot of burnout, but in the early days, we did see a lot of healthcare workers dying, nurses and doctors, because they were really at the front line and exposed to a lot of infection. And so this is why a lesson really is that we need planning in order to maintain essential health services, even when faced with a huge emergency. And I think this is something very important for the future, not just for pandemics, but also with climate hazards that we're seeing more frequently, floods, cyclones, heat waves, droughts. I think these emergencies actually are going to be much more frequent. May not be the whole world at the same time, the same emergency, but if you really look at climate hazards today, India, for example, and I think it's something like 300 out of the 365 days we had an emergency in one part of the country or the other, a climate emergency. So either there was a flood going on somewhere, a heat wave going on somewhere else. And so health systems really need to be able to cope with all of these different things. Now, just as an example of what happened in terms of global collaboration, solidarity, let's take vaccines, for example. Now, there were lots of wonderful things that happened because of science during the pandemic. A normal vaccine development takes about 10 to 15 years because each of the phases of vaccine development comes one after the other. It happens in sequence. You start with, the early work in the lab, then you go into animals, then you go into humans, a phase 1 for safety, then it goes into phase 2, phase 3 trials, then you apply for registration, approval, say with the FDA or with the regulatory agencies. And then the companies actually start ramping up the production once the regulatory agency has approved the vaccine. So it takes that long. The earliest it has taken in the past, in history, is the mumps vaccine, which took 4 years to develop. So that's been the past record. Now, during COVID, obviously, because of things happening in parallel, because of huge amounts of funding coming in, because of government and private sector working together, and also because the regulatory agencies were already thinking and planning in advance, data was being shared very frequently. So we at the WHO were really at the heart of all of this. Where early in 2020, we set out the standards so that companies knew what they were aiming for. So what we call a target product profile. So we said any vaccine for COVID, in order to be approved, should have at least 50% efficacy, and it should have a good safety profile. Now, of course, safety normally takes years to test. In this case, we knew we couldn't wait years, and so we had to apply, some amount of considered decision making by experts on the benefits versus the risks. And I think we were overall very lucky in that most of the vaccines that were developed and approved for use, both by WHO and by many regulatory agencies, turned out to be not only very efficacious, but also very safe. We also saw a lot of new platforms. I don't think anyone had heard of mRNA vaccines before the pandemic. And last year, of course, Katalin Kariko and Drew Weissman got the Nobel Prize for mRNA. Now, they'd been working on mRNA from the late 80s, early 90s, and had been struggling. Katalin Kariko's book really outlines the fact that as a woman scientist and working on something which was unheard of, which nobody really believed in could have any impact, and how she struggled for 30 years to work on mRNA. Her male colleague, Drew Weissman, also, but her struggles up, she was Hungarian, moved to the US. It's very interesting, her book. So they won it because mRNA, basically, there were two big vaccines, the Pfizer and the Moderna, both on this platform, but many others, including an Indian mRNA vaccine developed by a company called Genova, which has the added advantage of being heat stable. So these, and there were other new platforms, vaccine platforms. I think in terms of really moving the science of vaccine development, there were huge steps taken during the pandemic, both in terms of the platforms used, in terms of how quickly countries, had to roll out vaccination for their populations, but also on how regulatory agencies strengthened their own systems and were able to very speedily do what otherwise takes years. So in the beginning, we knew that there were a lot of COVID vaccines in development. In the end, maybe we had a dozen or so that were 12 to 15 vaccines that were used around the world. But the history suggested that only 7% of vaccines that start development in the lab actually succeed. And so this is why we encouraged as many groups as possible to go ahead. Now, what was clear to us was the fact that if we did get a vaccine, and that was still an if at that point in 2020, then we would have limited stocks of vaccine doses initially. And so we developed a prioritization framework and a facility called COVAX that was essentially meant to be a global effort to ensure that every country has access to vaccines as quickly as possible. So WHO, Gavi, which is a Global Alliance for Vaccines, and CEPI, which funds vaccine development, and a number of other agencies like UNICEF, FINE, UNITAID, and philanthropic agencies as well, and governments, especially of the high-income countries that were going to fund this initiative, came together and said, yes, we need to have this type of global effort. It hadn't been done before, so it was a new experiment. And the aim was to have about 2 billion vaccine doses available by the end of 2021 and vaccinate people around the world who were at highest risk of dying. So we said we knew by then, of course, that if the older you were and if you had underlying medical conditions like diabetes or hypertension, or if you were a frontline worker, then you were at high risk of getting infected and also getting seriously ill. And so the goal really was that as these vaccine doses became available, that COVAX would distribute them through a framework that had been agreed upon, which was considered equitable. And so every country in the world would get some vaccine so they could protect their doctors, nurses, and their elderly initially. But that wasn't what happened. So what actually happened was that there was, and this needed money, obviously, because the companies that were making the vaccines were not giving them away for free. So these doses had to be purchased. And so countries that had the financing to put in advance purchase agreements had first priority. And so we saw high-income countries, put in bulk purchase orders with all these companies, give huge advances, billions of dollars, and they spread their risk because you didn't know which vaccine was going to become successful, right? So countries that could afford it actually put in advances to 5, 6, 7 companies saying, whoever succeeds, whoever comes first, we want your doses. And so what happened was that COVAX was more or less reliant on a few companies, including the Serum Institute of India, which has huge capacity and can produce billions of doses and already supplies, about a third of the world's vaccine requirements for children. So in December of 2020, we had the first vaccines. We had Pfizer, Moderna, and AstraZeneca. All of them were approved around the same time. And we saw the first vaccination start in the United States, in the UK, in Europe, and so on. And of course, China had already started vaccinating their population, actually in July of 2020. Now, these vaccines which China made were tested and approved by their own government agencies, regulatory agencies. They came to the WHO much later for what we call pre-qualification or emergency authorization. And for that, you need a proper dossier of data and so on. So that took them much longer, but they started vaccinating their people. And they also sent vaccines to other countries, particularly Latin America and Africa. So there was that happening. But the real vaccination program in the rest of the world outside China started in December of 2020 and started progressing rapidly. And of course, all countries started with the most vulnerable populations. Now, throughout 2021, COVAX struggled till almost the end of 2021 because we were begging, pleading for vaccine doses, which we were not getting. Serum Institute of India also could not ship doses. They started, but then they had to redirect for India, which was facing the Delta wave also and very severe consequences of that. So ultimately, even though 189 countries signed up to COVAX as this grand idea, what actually happened was that it wasn't till the end of 21 that we were really able to ship sizable volumes of vaccines out to many countries. And so many countries, particularly in Africa, which has no vaccine manufacturing capacity to speak of, became very disillusioned by the response, the global response. And people also became very suspicious. And so finally, when vaccines started getting to many of the smaller countries in Africa, they were like, well, either these vaccines are being sent here because they're not needed elsewhere, or we've survived so long, do we really need to be vaccinated? By then, there was also a lot of vaccine hesitancy and so on. So I think it did have an impact, really. And at the end of, almost at the end of 22, when the WHO had said the majority of people should be vaccinated, 70% minimum was our goal by the middle of 22, there were still places in Africa where less than 3, 4, 5%, had been vaccinated. Of course, part of the problem was also the public health system could not cope with sudden adult vaccination. As you know, many countries have childhood vaccination programs, but very few have a well-developed adult vaccination programs. So you see, by mid-22, 68% of the world's population had received only had received at least one dose, but only 21% of people in low-income countries. And the colors on that map show you the coverage. Now, on R&D, I already mentioned that, I think the world did really, really well. And as far as the WHO is concerned, we have something called the R&D blueprint for epidemics, which was set up after the West Africa Ebola outbreak. And we had two challenges here. One was, how do we accelerate research to help contain the spread of the virus and to provide care for those affected? And the second is, what do we do for future epidemics and pandemics? And really what happened was that very early in 2020, we brought together scientists from around the world. The first meeting was in February of 2020 in person in Geneva, but subsequently everything was online. And it was amazing to have, literally thousands of scientists coming together, working in small groups on different topics that were important. Everything from understanding the origin of the virus, which of course is still a question mark. We still don't have the final answer to that. Where did the SARS-CoV-2 virus emerge and how? So that's a big question mark. But in terms of understanding the pathology, the pathogenesis, the risk factors, how it's transmitted, we had a lot of engineers, aerosol engineers who came into the scene. And we've learned so much about transmission of pathogens, which we didn't know before the pandemic. And so we can protect ourselves much better with that understanding, all the way through immunology, virology, development of diagnostics, vaccines. So for all of this, we needed these scientists working together. And I must say that regardless of the geopolitics, we had this amazing collaboration between scientists, Chinese scientists, American scientists, Indian scientists, everyone working together, really, no one holding back. And the other thing, of course, was that normally academics would like to publish their work before they share. But in this case, that barrier was not there. Everyone was sharing data in real time. And of course, journals also made a commitment to publish papers, regardless of whether the data was already public. So there were a lot of things that happened during the pandemic. Now, the downside, of course, was that while scientists were sharing all the information quite openly, once it went into private sector hands, then, of course, things were different. So, for example, we did request the mRNA, the big companies that were developing the mRNA vaccines, to share the technology. As soon as it became clear that the vaccines were working well, the trial results came out, said, why don't you share this technology with a few other companies around the world that have the capacity to make it? And so we can scale up the production of these vaccines much faster, rather than just you holding on to this and trying to do it. We had a request by India and South Africa at the World Trade Organization at the same time, asking for a waiver of intellectual property during pandemics, particularly for these kind of life-saving products like vaccines. But unfortunately, we made very little progress during the pandemic. There was some sharing of technology, no doubt, but it was on a voluntary basis. And what we were asking for was sharing of technology in a transparent way, which could allow WHO, an organization like the Medicines Patent Pool, to be able to share the technology transparently and inclusively and equitably to ensure, benefits reach everyone. So I think we still have a lot of work to do in that space, particularly since a lot of the research that led to these vaccines were actually funded by taxpayer money. So it was publicly funded R&D. The NIH, for example, that spends about $40 billion a year on research, is responsible for a lot of those developments and discoveries, which ultimately resulted in the mRNA vaccine. But the end product, then, the intellectual property, is fully under the control of whichever company has bought that license. And so what we're arguing and continue to argue for is that this model needs to change, especially for life-saving products that must be considered public goods. If they're funded through philanthropy or through public financing, then the product must also have a clause which enables access. And this is not just pandemics, by the way, it applies to something like insulin. Many people, even in this country, do not have access to insulin because it's priced out of the range, So it's a life-saving, and, Banting and Best, when they discovered insulin, they wanted it to be a public good. And so they actually charged $1 for the IP and said that this must be made available to people of the world, because people used to die of diabetes before insulin was discovered by them. But that's the reality of the world, we live in today. Okay, so let's keep moving. I think a lot of this is really about what we learned about R&D, about developing vaccines and drugs. And one of the things that there's now a big focus on, apart from this whole thing of sharing intellectual property, is really on developing manufacturing capacity in Africa. And there's a lot of funding that's going into that, building capacity and also building human resources. Now, if you look at this map, just again to show that research, the collaboration that WHO had set up really involved people from all around the world. There were over 1,000 institutions participating. This is the R&D blueprint, which is now being redesigned really to look at more emerging pathogens. And I think I talked about these issues already, where the bottom line is that when research agreements where big funding goes in, especially from public agencies, it should include defined access clauses. So some of the lessons really around this were that global and national preparedness clearly are important, that you probably need, every country needs a national R&D blueprint similar to the one that I just talked about at the WHO, which mentions the prioritized list of pathogens and how is the country really going to respond if there's an outbreak. Clinical trials, rapid response trials, investing more, of course, in the science of understanding how to develop vaccines and drugs, regulatory pathways, social science research, which is often neglected. And I know many of you are interested on that, on vaccine acceptance, on the feasibility, addressing myths and misconceptions. I think one of the big areas of work for the future really is going to be what we call now the infodemic. The DG of WHO actually used that term in February of 2020. He said, along with the viral epidemic, we also have an infodemic, which is an explosion of knowledge, information on the available, especially through social media. And a lot of it is actually mis and disinformation. And it's very difficult for an ordinary person who's not maybe scientifically educated to be able to tell the difference. And there were so many conspiracy theories that were being floated, etc. So I'm going to skip a lot of this. Yes, so this is what he said. We're not just fighting an epidemic, we're fighting an infodemic, and that fake news spreads faster, more easily than this virus, and is just as dangerous. And we see that happening in so many areas, right? But when it comes to vaccines,
they say a lie travels around the world 3 times before the truth has its shoes laced.
That's right. A lie travels around the world 3 times faster than the truth. And also because of social media now. So this was the first pandemic, of course, in the social media age. So again, that was something we had to deal with and learn, and public health officials really had not dealt with that kind of challenge before. And so we had to reinvent how you do risk communication and so on. So this is a multidisciplinary area of work. Of course, every government needs to take stock of how they performed, what happened, and every country, I think, did well probably in some areas and not well in other areas. And I think unless one understand that and act on it, one of the things is that communities need to be engaged, and many countries did not do that. So the ones that had a better response, I think, are the ones where there was a lot of trust already between governments and public, where there was open and transparent communication, and where there was a dialogue with the community or civil society, rather than top-down orders, which were often, incomprehensible to people, and also engaging experts from across disciplines, not just the medical folks, but really engaging behavioral scientists, etc., is all going to be very important. So I had some slides on, where we are with the global process establishing the treaty for pandemic prevention. I mentioned at the beginning, this is still being debated at the WHO because there were a couple of clauses countries could not agree on. These were mostly around sharing of countermeasures, what we call countermeasures, which is drugs, diagnostics, vaccines. How do you share them equitably, and how do you share data also? So there are still some sticking points, and these are going to be further negotiated. They've given themselves another year of time to come back, because every country that's a member of WHO ultimately would have to agree to this. So principles, priorities, and targets need to be set up, and a One Health approach that connects the health of humans, animals, and the planet. That's also at the very center of of this pandemic treaty. So some of the sticky issues still are around pathogen access and benefit sharing, the financing for pandemic preparedness. Again, low-income countries need to really invest in their health systems. Where are they going to get the funding from? And the other very important point that's, I think, recognized by everyone is that a pandemic can start anywhere in the world. And, all of you would have heard often, nobody is safe until everybody is safe. It is true that it's going to take only about 24 to 36 hours for a virus to spread from any remote village in the world, to cities around the world. And because we're so urbanized now, it's very easy for viruses to spread once it enters. So nobody can rest saying, well, this may happen in a remote corner of some continent, we're not going to be impacted. That's not the case. So I think the sooner the world recognizes that, has a financing mechanism, which there is, by the way, it's been set up now. It doesn't have a lot of money in it. It has about $2 billion. What is needed is about a minimum of $10 billion a year to really invest in health systems. And then, of course, we have to. So maybe I will end with just a few remarks on the top 10 risks to health. And this is something that the World Economic Forum brings out, the Global Risks Report. And if you look at short-term and longer-term risks, all of the green boxes are environmental risks. So over the medium term, really the risks to human health, well-being are going to be failure to mitigate or adapt to climate change, natural disasters, extreme weather events, biodiversity loss, ecosystem collapse, natural resource crisis, large-scale environmental damage incidents, and the others are societal and geopolitical risks. And we also have, a list of 21st century health challenges that we came out with. Again, on the top is, the climate and health interaction, but also stopping infectious diseases and preparing for epidemics and earning public trust. That's also a challenge. No, I'm going to skip a lot of this now. And hopefully, because this is about climate change and we can always come back to that. So I think I'll end with really summarizing some of the things that I think I talked about. Essentially boils down to having good governance and, of course, investing in infrastructure, health systems I'm talking about here, and having sustainable financing, both at the global and national level. So one of the things that's being discussed also at the World Health Assembly is how do you fund WHO better? Because WHO has an annual budget which is less than the budget of one of the large tertiary care hospitals in the United States. And WHO is responsible for the health of the world's population and is also called upon by a large number of countries to do a large number of things. So really, the financing needs to step up a lot. Countries also need to invest more in health, not just in building bigger hospitals, but also in public health, which means investing in all of the primary care facilities, the supply chains, the data system, but most importantly, the health workforce. And after the pandemic, many nurses and doctors actually left the workforce. Of course, many of them had died, but there is a global shortage of nurses, for example. 18 million nurses are needed around the world. So it's not just doctors and nurses, but a number of other staff that one needs. So investing in human capital is going to be very important. I think I've spoken enough about the new model of R&D we need, and thinking about life-saving products as public goods, and not for a few companies to make a lot of profits out of. A One Health approach, which is important today because of the risk of zoonotic infections, but also because the loss of biodiversity and the loss of species at a very rapid rate is going to impact human beings also in the future. Risk communication, trust, social media. So I think public health experts need training. A lot of people were struggling during the pandemic of how to communicate You've got to be you also have to have the capacity and ability to listen and respond to what people are worried about, not just keep repeating the same messages that sometimes we think should be heard. And then finally, to come out of something that affects people around the world, could be a pandemic, could be the impacts of climate change, could be something like antimicrobial resistance, which is going to impact all of us. You need global solidarity and cooperation. It cannot be done in a country by country approach. There are going to be some common global rules, mechanisms, etc., which will have to be put in place. And so these are some of, I think, the challenges for the future. But of course, there must be many more that I haven't really touched on today. But I'm going to stop here and turn it over back to you, Tim, so that we can go into the discussion.
Thank you very much. Let's thank our speaker.
Thank you.
Okay, we're going to have some question and answers now. If you are in the room and you're going to ask a question, please use the mics in front of you. If you press them once, they should turn red. Then people online will be able to hear you. When you finish, press it again and turn it off. And I'm going to try to alternate between online and in-room questions so that we're not discriminating against one group or the other. So let me start with the first online question that's been there for a while. In the US, it seemed one public health lesson was that talking about disease and medicine in a nuanced scientific way was not that effective, and that targeted messaging proved to be better. Is that an accurate understanding, and how does that inform public health responses to outbreaks in the future?
Yes, so it's a very good question, and it, I think, is related to what I was saying about risk communication, public health communication, and how we really need to think about what are those effective ways. And it's not enough for a scientist to stand up and say, look, I'm telling you, this is it. This is what we know. And so you have to do this, this, and this. And at the WHO also, we were constantly innovating because our communications department was doing something called social listening. And they were trying to hear what people were really discussing on, Facebook or WhatsApp or whatever a lot of people use. What were the doubts? What were the fears? What were the concerns that people had? And then we tried to come out with messaging, which was in simple language, to address those issues. So I think rather than brushing aside what we think are foolish, we may think are irrational or foolish questions, we have to engage with that audience because everyone has a different level of understanding. And also scientists also need to be humble because we saw the science changed very rapidly, right? And so what you know today could be superseded by new findings tomorrow. And so that was also an aspect that we had to learn how to deal with. But one other thing I think that happened was that a lot of debate was happening in the public. Debate between scientists has always been there, but this time it was all being amplified and it was visible to everybody. So it looked as though scientists couldn't agree with each other, that they were debating, that, and so people are not used to that, I think, public type of debate between scientists. And so that may also have contributed to confusing people. And finally, there is, unfortunately now, quite a significant, a substantive group that promotes mis and disinformation for whatever reason. I don't understand their incentives to do something like promoting, vaccine hesitancy, but they do. And that has a very big influence on people. And so that is a much more difficult, I think, challenge. But again, it is the public health experts ultimately who will have to deal with this and find ways.
How do we use this?
Right. Hi, I wanted to ask you about the role of a scientist. They're held in low regard in general, and more so since the pandemic. As chief scientist, as the new chief scientist of the World Health Organization, what particular challenges did you face in doing your job?
Yes, thank you for that question. I think, there were many surveys done actually about science and scientists and what the public thought of them. And overall, I think through the pandemic, that was one group that actually scored better. And the people who scored at the bottom were politicians and journalists. Yeah. But there were some fabulous science journalists, by the way, that I used to follow, who really simplified science for the general public. And I think they do a great service. The challenges were really about the misinformation and how to handle that. So when there's a conspiracy theory going around, how do you rationally counter that? For example, there were conspiracy theories that vaccines were going to be ways in which governments or corporations could control you because chips were going to be inserted with the vaccine. Now, from a scientific point of view, very difficult to come up with, because that's just something that is so random and people just believe it or don't believe it. So what we tried to do was to talk about these things. For example, there were some genuine concerns that people had about, can vaccines cause infertility? Can they cause menstrual abnormalities? Can they cause long-term problems? And how do you know? Because these vaccines have only been around for a few months, So I think that those are genuine questions. And so we had to be very open and say, to the best of our knowledge, this is what we know today. We're tracking very closely. There were cases, of course, of side effects. You remember that there were some clotting disorders associated with one of the vaccines. Another one was causing myocarditis in young men. So as we got to know of these things, we used to come up and say, this is what we've heard, but this is happening in 4 out of 1 million people who've been vaccinated. Whereas if you don't get vaccinated, you're going to have 100 times higher risk of dying, with COVID or getting a very severe complication. So it's a benefit versus a risk. So I think that honesty, transparency, and humility are all important attributes, but there is no perfect answer to your question. But I do hope that trust in science hopefully is better now than it was. No, you don't think so?
Okay. Yeah, let me throw in one more question from online. What are your thoughts regarding the response of the aviation transportation system? Flights canceled, international travel halted, presumably as a consequence of the COVID pandemic.
So this was actually one of the most controversial aspects of what happened during the pandemic. Now, the international health regulations state that as far as possible, international travel and trade should be protected because it has such huge impacts on economies of countries. But actually what happened was that everybody just, reacted to what was happening and started closing borders. And I think that it is reasonable and it can be justified, I think, for a certain period of time. If you want to protect your citizens from a threat, I think it's rational to do that for a period of time. But what was not rational was that countries, every time there was a new variant, suddenly the flights are canceled, borders are closed. Now we know that that's not going to stop that variant from coming. We knew enough by then. So for example, when the Omicron was, this happened with every variant, but Omicron was detected by scientists in Southern Africa, in Cape Town, Namibia, and so on, very quickly. And the amazingly fast detection and also response and informing of the WHO. So Omicron, within a matter of 2 to 3 weeks, we had been informed and it was already declared as a variant of concern. Several countries immediately stopped flights to and trade from those countries in Southern Africa, and it impacted their economy hugely. So the question that those governments were asking really, and I think President Cyril Ramaphosa was very vocal about it, and he said, why should we be expected to share data on variants if this is the response that the international community is going to put on us? After all, we're trying to protect you by telling you about this new variant. And sure enough, in a matter of a few days, this variant was in every country in the world. viruses travel much faster than, human brains or action can do. So there were some very irrational things that happened and that really impacted countries. So one of the things that's being looked at now is the international health regulations are being revised. But then countries must also then agree to follow those rules and regulations when there is a crisis.
Thank you. Next question was here.
Thank you. Such a comprehensive and interesting presentation. I have two questions, one forward-looking about antimicrobial resistance and the very widespread use of antibiotics now in big farming and how that may be a real crisis waiting to happen. And then looking back, you mentioned that scientists had worked very well together as a whole and been quite transparent. There was a lot circulating about China's refusal to allow the WHO delegation to go in and see the lab in Wuhan and the actual site of the proposed outbreak. So if it's not too political, if you could comment on that, that would be fascinating.
Sure. So maybe I can take that first. Yes, that is still one of the very big gaps in knowledge. We don't know exactly how SARS-CoV-2 happened to infect the first human beings. We think a lot of people believe that it's a virus that's present in bats in nature and that it got transmitted to one of the animals in the wet market, an intermediate. And this is because SARS-1 was actually, the research was done and it was shown that while it was a coronavirus from bats, it infected civet cats. And civet cats are farmed, I think, in China, and then it jumped to humans and then got the ability to spread from human to human. And we think that the same pathway may have happened, but we don't know what that intermediate animal was. There's also the other theory that it was an accidental leak from the lab in Wuhan. And for any of these theories to be confirmed, one would need to go back and reconstruct the story, see all the data, and that has not happened. So there's a big gap there. Antimicrobial resistance, I think, is a large topic by itself, but you're absolutely right that there are many practices, again, that we're doing now, like widespread use of antibiotics as growth promoters for disease prevention, especially in the big farms, poultry, as well as cattle and pigs, etc. That is one of the major contributors, but there are other contributors as well, including the irrational use of antibiotics. And unfortunately, during the pandemic, in many countries, including in India, the use of antibiotics went up many times because even though it's a viral infection, antibiotics don't work, but people were still taking them, doctors were still prescribing them. And so it's only got worse after that. There are no new antibiotics being developed at the speed at which we are losing the old ones because companies are not investing in the R&D for antibiotics. It's not something that is going to be profitable. So many companies, large ones, multinationals that had a large portfolio of research on infectious diseases have all withdrawn. And so we only now have to rely on government funding startups to do that kind of research. So we need both the prevention on things like what you mentioned, but also the new antibiotics being developed and new antivirals for that matter. We don't really have good antivirals around except for a couple. So that's again a big gap where industry is not investing.
Well, thank you, but I think we're out of time. So maybe we can see if the speaker would be willing to stay later. We have to wrap this for the online version. Let's start by thanking our speaker again. That is our job. I want to thank the audience for attending, both those who are online and those who are here in the room. A YouTube recording of this will be posted on the East West Center's YouTube channel and posted on the website's event page. So you can find this later. And there will be a next talk on July 17th in the research program speaker series. This will be a hybrid symposium once again, both online and in the room. And it will be Dr. Samantha Keys-Ryan on water security in the Pacific. So with that, let me thank everybody again for their participation. And again, thank our speaker for a wonderful, engaging talk.
Thank you. Thank you very much.